Hello, I'm Norman Swan. Welcome to this program on improving eye health in Indigenous communities. Indigenous children are usually born with better eyesight than non-Indigenous children, yet by the time they reach adulthood, they're 6 times more likely to be blind and 3 times more likely to have low vision. And most of that vision loss is preventable, and certainly most of it's treatable. This program covers different eye diseases and how to treat and prevent them, and we have 2 filmed case studies as well. You'll find a number of useful resources available on the Rural Health Education Foundation's website, rhef.com.au. Now let's meet our panel. Tim Henderson is an eye specialist from Central Australia. Welcome, Tim.
Hello, thank you.
Tim visits over 30 remote Indigenous communities each year with the eye team, providing a comprehensive specialist outreach program. He's also senior lecturer in ophthalmology at the Northern Territory Clinical School of Flinders University. Anna Morse is an optometrist and the project manager of the Aboriginal Eye Care Service with the Indigenous Centre for Eye Care Education. That's based in Darwin. Welcome, Anna.
Thanks, Norman.
Anna provides and facilitates optometry services to many remote community health centres and Aboriginal medical services across all regions of the Northern Territory. She also provides training in eye health care for primary healthcare staff. Barbara Connor is the Regional Eye Health Coordinator from Woolloongabba in Queensland. Barbara is a descendant of the Nunakal tribe from North Stradbroke Island and currently works for the Aboriginal and Torres Strait Islander Community Health Service, providing services at Woolloongabba and outreach across southeast Queensland. Welcome.
Thanks, Norman.
Hugh Taylor is Melbourne Laureate Professor holding the Harold Mitchell Chair of Indigenous Eye Health at the University of Melbourne. Welcome, Hugh.
Thank you, Norman.
Hugh's research interests include blindness prevention strategies, infectious causes of blindness, and the relationship between medicine, public health and health economics. His current work particularly focuses on Aboriginal eye health and trachoma. So welcome to you all.
Thanks.
Hugh, how closely tied in, just expand a little bit on those statistics I gave earlier in terms of the eyes.
Yeah, sure. Well, as you said, Norman, Aboriginal children have less poor vision, a fifth less poor vision, and in fact much better vision than mainstream kids. But by the time Aboriginal and Torres Strait Islander adults reach the age of 40 or above, they have 6 times as much blindness. And almost all that blindness is unnecessary. It's either preventable or treatable. 30% or 32% of the blindness is due to cataract. And then we have refractive error that cause about 14%, and diabetes and trachoma both cause about 9% of blindness. And as I said, 94% of this vision loss is unnecessary. But 1/3 of the people have never had an eye exam. So they have not had the treatment or the prevention that they need.
Barbara, this has to have enormous impact on communities.
Yes, it does. It's basically is the health of the individual with diabetes, is the eating habits, also with controlling how much they eat, what intake they take with their sugar, and also hygiene. It's trachoma is a very important issue too.
And Anna, the optometrist is often the first port of call for finding out a lot of these things.
Yeah, absolutely. So I guess the main trigger for people to have their eyes checked is them noticing a change in their vision. So often the first person to see is an optometrist. It's not uncommon for the optometrist to pick up diabetic retinopathy, even perhaps when people don't know that they're diabetic yet. So yeah, optometrists are a vital link in the chain in the eye care team.
And not enough of them?
No, apparently not, especially in the very remote locations. We can always do with more optometrists providing services there.
And Hugh, you've got research which suggests that the access to optometrists is directly related to the vision of a community.
Yes, there's data that shows that the longer an optometrist is actually working in an Aboriginal medical service or an AMS, the better the vision and eye health of the people in that community. Whereas there's no relationship between the number of optometrists or the amount of time they're available in the community or the town itself.
It's inappropriate services.
So it's the appropriate, culturally acceptable services provided within the AMS really lead to much better outcomes.
So what are the trends here, Tim? I mean, you think with all this discussion about diabetes and everything else that we should be tracking seriously downwards?
I think the coverage for screening populations is improving. I think there's a much better understanding of the range of disease issues that the population faces. But there are significant challenges to getting enough outreach services in place, really, that we ideally need 3 optometry visits per eye specialist visit to begin to get the comprehensive coverage and pick up the rate of problems that exist.
But we are getting a bit better, aren't we, Hugh? Please tell us we're getting a bit better.
Well, yeah, we are getting a little bit better. I mean, in the mid-70s, when I first started working in this area with Fred Hollows, the rate of blindness in Aboriginal people was 8 times higher than it is in mainstream.
And now it's only 6 times.
Now it's only 6.
So
yeah,
it's still falling.
you know, it's a little bit better, but we've still got a long way to go.
Much difference between city and country, Anna?
Yeah, perhaps surprisingly not so much. So in the Indigenous Eye Health Survey particularly showed that vision impairment and blindness didn't vary much across whether people were in urban location, rural
But
or
presumably
remote.
not so much trachoma in cities.
Not so much trachoma, so there were slight differences in specific conditions such as trachoma, blinding cataract, but overall rates of vision impairment and blindness, which can indicate that while services may be available in perhaps an urban location, they're not necessarily accessible, so not necessarily available through an Aboriginal community-controlled health organisation or in a setting where people feel comfortable and free to access that service.
What other barriers do you think there are for people accessing services?
Is the service delivery within the regions, in the outer regions, outside of the urban. There's not enough services in the rural and remote areas, which is possibly across the whole of Australia, with optometry followed through by ophthalmology. So I say accessing services, transport to cities if they do need the treatment, but that's a large problem within those areas. So I say not having the service deliveries out there in the rural and remote areas.
And even something as simple as refractive error, Hugh, we're not getting right.
Well, refractive error causes half of the vision loss in Aboriginal people. And this is for distance vision, but the other thing that's even more important, I think, is poor near vision. That 40% of Aboriginal and Torres Strait Islander adults cannot see normal size print because they just don't have the right pair of reading glasses. And so we really need to make sure that we provide those refraction services with visiting optometry and visiting eye services, so we can cure uncorrected refractive error instantaneously with a pair of glasses.
So it's presbyopia as well we're missing?
Yeah, absolutely, and that's often one of the overlooked refractive errors. And studies, especially worldwide, have shown that the impact on people's quality of life just with a pair of reading glasses can be significant. So everything that you do looking up close, especially in this day and age, which is about half of your day, is affected.
Barbara, to what extent do you think GPs working in Aboriginal medical services are actually doing both distance vision, both checking distance vision and near vision?
It'll be visual acuity for distance. It's tested, but not for reading. It's basically the optometrist, when they speak to the GP speaks to the client, they will bring forward that they can't read the newspaper or they can't see the distance, and it's referral to an optometrist.
So, Tim, this is outrageous. So we're missing presbyopia because people aren't just doing a simple check with a standardised font size chart.
At the very least, you can at least ask them if they're able to read small print or see it.
And give it to them. So it's a big message from this programme. If you're a general practitioner, you should be checking for presbyopia, at least in a crude way.
Yeah, and certainly in every health check, one should just, and even if it's a question of picking up a book or a paper on the desk and saying, can you see this print? And if it's somebody who doesn't read, you can still ask them to point out the letters or which way the E's are pointing.
So don't take it for granted.
Don't take it for granted.
Yes, it's fine. Actually test it. Because if they're not, even if they can't read, they're still requiring see things near our brain.
You need good vision to be able to thread a needle, to clean a gun, to adjust a carburettor, even to sort of cook and prepare food, let alone checking your medicines or your blood sugars.
What about cataract, Tim?
Oh, cataract's well worth picking up because the impact that you can have from cataract surgery, which I think we'll cover in a bit more detail later, is just so dramatic. Overall, we probably reckon around 3% of Indigenous adults suffer from cataract vision loss, and blinding cataract is 12 times more common in the Indigenous populations that we look after. Of those, 65% needing cataract surgery have been operated on, which leaves a significant proportion that still need surgery.
And diabetic retinopathy, Anna?
Yeah, so I guess that follows trends of significant increases in diabetes in itself compared to 2 or even 1 generation ago where there was hardly any at all, to now rates of around or above 30% in Aboriginal people. So following along with that is obviously higher prevalence of diabetic retinopathy. And diabetic retinopathy is more common also if people, along with diabetes, have hypertension and high cholesterol as well. So sort of the triad of those increases your risks of getting diabetic retinopathy. Importantly, only about 1 in 5 Aboriginal people with diabetes had a recent eye exam, so the required eye exam in the previous 1 year, which means there is a chance of retinopathy progressing without it being detected.
And all this is overlaid, Hugh, on a disparity in the provision of services across Australia.
Yes, well, if you look at the distribution of eye services, either performed by an optometrist or ophthalmologist, but you see how patchy and variable they are across the country. And in the remote areas, one would need to increase the services at least 3 or 4-fold to bring them up to the level that the rest of the country enjoys.
Tim,
so there's clearly a shortage of services.
To what extent are glaucoma and macular degeneration prevalent in Aboriginal communities?
Very low numbers. It's really not that significant a contributor to the population that we're looking after.
What are the key health promotion messages then that we're trying to get over here, Anna, in eye health?
Yep, so there's a few important messages. I guess a really important one, given the fact that a lot of this vision impairment is preventable or treatable, is for people to be aware that losing vision is not a normal part of getting older. So there's something that can be done about it. Important in that is you should get your eyes checked regularly. So get your eyes checked once every 2 years or once every year if you're diabetic. And then relating to particular conditions such as trachoma is around keeping your face clean and blowing your nose for the kids as well. And then tying in with diabetic retinopathy is if you keep good care of your general health, then that can protect your eyes also.
And smoking, presumably, or did you say that?
I didn't say that, but yeah, absolutely.
Smoke gets in your eyes.
It's also a very bad combination with diabetes as well.
Yeah.
So just Hugh, you're trying to get the health check changed for Aboriginal people to be much more systematic about the eyes.
There's a lot of talk about whether one should have a vertical program or a horizontal program or a body part or a holistic. And what's really important is to have comprehensive primary care doing the basic eye care that they need to do. And that basic eye care is to make sure, first of all, that people having a health check get their vision properly checked, particularly near vision, as we were talking about. Any problems with near vision, refer them. You don't have to manage that, just initiate the referral. And the second thing is people with diabetes. Make sure that Aboriginal and Torres Strait Islander people with diabetes get their eyes examined every year. At the moment, only 1 in 5 are getting that. It's just terrible.
Now let's look at an Aboriginal medical service in Katherine, which has an eye health program with a regional eye health coordinator who's called Dorothy Butler. Dorothy provides screening and education and coordinates specialist eye services.
My name is Dorothy Butler. I'm the Eye Health Coordinator at Welly Medical Centre in Katherine in the Northern Territory. The main eye health problems that come through my clinic is diabetics with diabetic retinopathy, cataracts, pterygiums. They're basically the most important ones.
Hey Dot. Hey,
Hi Anna, what's the problem?
Got a referral here. IC has been working in close collaboration with the Worley Eye Program and particularly with the Regional Eye Health Coordinator, Dot Butler, for about the past 4 years. And that's been to provide optometry services regularly here so that patients who are current clients of Worley can access eye care regularly.
Now look up.
The main eye health problems in the top end are, I guess, similar to the main eye health problems in Indigenous communities. particularly in remote communities in Australia.
Right, chin forward onto here now.
Leading causes of vision impairment and blindness are refractive error. So that means people who need spectacles to correct their vision but don't have spectacles. Also cataract, and there's much higher rates of blinding cataract amongst Aboriginal people for a number of reasons, including lack of access to surgery or fear around having surgery.
Oh, well, that all looks fine.
So if you have a look here, Rayleigh, this is like an example of an eye that's just cut in half so we can see. Another leading cause is diabetic retinopathy. So that's where there's bleeding on the retina, which if unchecked can cause a vision loss which generally can't be returned. Particular emphasis is given to diabetic patients so that they can have annual dilated retinal exams. Blood vessels in the retina looks normal.
What I'm going to do today is take a photograph of your eye to check if there's any changes with your diabetes in your eyes. All the diabetics have to be screened once a year. And so I try to make it out to each community once a year and try to see as many diabetics as possible. That's your macula there, that's your seeing part of your eye, and that's nice and clean. This is your optic nerve here at the front, and you've got a very good eye. No diabetic retinopathy, no changes in your eye. So I'll see you again in 1 year's time. Okay. Also we see all the clients that require reading glasses, and I organise classes for them and do ready-made readers for them. So what you need to do is select a frame, and this frame...
Across Australia, it was estimated there were about 120,000 Aboriginal people who were not receiving, you know, a basic standard level of eye care that they should be receiving.
Oh, they're better.
They're nice. I reckon they look better.
The IC's programs enable access to low-cost spectacles, and that's been recognised as one of the main barriers to improved vision in Aboriginal people is inability to affordably correct refractive error.
Oh, these are much better.
Morning, Michelle.
There are so many links in the chain in the eye health system, from early detection, so that involves Aboriginal health workers especially, also people wanting to access those services, and that's where the role of the Regional Eye Health Coordinator is so important.
Monday, would you like to come this way? I'm going to check your vision. Hand like that, over your eye, then you look up there and you point. Right, cover one eye up, start from the top and point which way it's going.
They provide that vital link to the community as trusted members of the community in which they live, and also making sure that the optometrists who provide the services are culturally aware and practice in a culturally appropriate way to make people feel comfortable about accessing those services, and then ensuring that referrals to other levels of eye care are followed through.
The challenge I have from running the program is getting the clients to come in, so to make sure that my clients see the optometrist. We have a system here where I've got a bus driver. I give them the list, they go out to the communities, pick the clients up, bring them here and then take them back again.
Right, hello Tuan.
Hello.
Come to have your eyes tested. You had them tested before?
No.
Good, okay. So
The optometrist visits Worley 3 to 4 times a year. We do normally 4 to 5 days service.
R M V.
I decided to remote area locums for a number of reasons. Firstly, professionally, I think there's a great value in being able to provide eye care to remote areas. I find that particularly enjoyable. I think professionally it's a challenge because obviously the clinical work that we do here is far different than we do in our own practices at home. Do you notice any difference if I do that? What difference do you notice?
It'll like go bigger.
Go bigger. Good. This one.
And we're finding that the more locum optometrists get involved, the more it spreads by word of mouth about how great the program is, and we're continually contacted by optometrists around the country who are keen to get involved in our programs.
Our thanks to Worley Worlinjang Aboriginal Health Service staff and clients for allowing us to film their eye health program. Tim, talk to us a bit more about cataracts in Aboriginal communities, Torres Strait Islander communities.
Well, I think as we mentioned earlier, they're much more common proportionally within the population, and the impact that we can have by undertaking cataract surgery is really quite considerable, and the aim is to pick people up early enough to treat them promptly. There's been quite a lot of work done within the looking at the figures for the rates of cataract surgery being undertaken, and even in the relatively established outreach services, I think we've got a graphic which just shows this. The Central Australian outreach is doing okay, and that's a relatively well established program, but some of the programs that are outreach services are developing, there's really quite low rates of picking people up and undertaking cataract surgery, and all of them are well below the national average, as you can see on there.
And in fact, the actual rate should be higher than the national average.
The actual rate should be much higher because the rate of cataracts in the population is much greater.
So, Hugh, what do we need here? I mean, do we need to get, son of Fred back to get barefoot eye doctors into Aboriginal communities?
Cam Hollows is training, I think, to be an orthopaedic surgeon rather than ophthalmic surgeon, so we won't get that son of Fred. But and with the Trachoma program back in the 70s, we had a number of surgical blitzes, and an army field hospital at Armata, another one at Utopia, and then through the 80s and 90s those were repeated. And that's not the way to go now. What we need to do is we need to build capacity. Blinding cataract is 12 times more common in Aboriginal people. Cataract surgery is 7 times less common. So it's that lack of surgery. Now, the number of cataract operations we have to do would only be of the order of 2,000 or 3,000 additional cataract operations for Aboriginal people each year. And when we do 250,000 cataract operations across the country, that's only adding...
You should be able to squeeze in another 3,000.
It's not a big deal. But it's the organisation of the services to get that done. And so it's the commitment of recognition of the importance and getting people off the waiting list and getting them operated.
And do you think people are competent at diagnosing cataracts when they're not ophthalmic?
Possibly. I guess there's a few different ways you could pick it up. The best way to pick it up is with a slit lamp. So it depends how competent people feel using a slit lamp for a basic assessment of the anterior eye. Yeah, that's the best way to pick it up. If it is a more dense cataract, you can pick it up with a pen torch observation, but you would hope that you wouldn't have to wait until it looks that obvious before people are proceeding to surgery.
How do you suggest the GP approach this in an Aboriginal medical service? What concerned about cataracts? Because fundoscopy itself might not get you there.
I think if you're taking the basic steps of checking vision and finding that there's something that's not going to be corrected with glasses, then the next thing to look for is cataracts because of the relative frequency with which they occur.
And are they different from cataracts in the mainstream community?
The principal process is related to age, so the longer you live, the more likely you are to develop a cataract, but the incidence of cataracts is greater if there are high levels of diabetes. It tends to cause cataracts to develop sooner. And presumably they're later, so they're harder to operate on? They are certainly much more challenging to operate on. Patients will tend to present later, and so the cataracts are more advanced. The surgical procedure is still essentially the same, but can be more challenging if a cataract is very advanced. So can you do this in the country hospital, or are they having to go to a major centre? It's appropriate that it's done in a sterile operating environment. In other words, the highest possible standards of care should be provided for every single patient. So you do it in Alice, do you? Do it in Alice Springs in a proper sterile theatre. So people have to leave their communities, which they won't like? They do have to leave their communities, but as I say to people who've asked, I wouldn't do this to my mother in the middle of a remote community, so I'm not going to do it to anybody else. But equally, you want to provide the best care you can in the most comfortable environment. And so we do go a long way to trying to make patients feel as comfortable as possible. We will encourage people to bring with them health workers from the community or relatives, and somebody who can sit with them and translate if English is not their first language. Often go through things in quite a lot of detail, explaining the process for what they can expect, so that actually there are no surprises along the route, and the staff are very used to looking after patients who are not comfortable about being in theatre at all. And do you fully correct with the intraocular lens? Yes, you do. You aim for emmetropia. That is not long-sighted or short-sighted. In other words, giving people good distance vision, and they'll just need reading glasses on top of that for close activity. And Hugh, and so what about, sorry, before we go to Hugh, what about follow-up back? Normally they're seen the initial morning straight after surgery, and provided everything's satisfactory, which is the case for virtually all patients, they can go home. And we will then review them when we're next in the community. Ideally, they should have an optometry check after around 6 weeks, by which time the refractive instability will have stabilised, and patients are given drops to continue to take over the first couple of weeks whilst things settle down. Hugh, I first met you when you were living in America, and you did this study of Chesapeake fishermen. Yep. And related cataract to UV light, but you've gone back a bit on that, haven't you, over the years?
No, UV light is an important cause of cortical opacity, and but the population attributable risk is relatively small. And so in temperate areas of Australia, UV accounts for about 6% increased risk of cataract. Smoking accounts for about 6 or 8% increased risk of cataract. And diabetes accounts for, again, about a 6% increased risk of cataract. The important thing with cataract, though, is that everybody will develop cataract if they live long enough. And so the solution to cataract vision loss or blindness is not trying to get lifelong protection, which is just really hard to do. One should minimise your UV exposure, of course, but even minimising it, you still run the risk of developing cataracts. What we need to do is have proper services to deal with it.
So it's minimally preventable?
It's minimally preventable,
unless you can
but
stop getting
maximally treatable. That's the thing. I mean, modern cataract surgery is miraculous and can restore very good vision very quickly, very reliably, so that the real emphasis is on the provision of surgery.
And how good do you think Aboriginal medical services are at the cataract? How confident they feel, do you think, Barbara?
With a good optometry service there to pick up the cataracts, the referral process in the urban areas is there is a long waiting list, but in the rural and remote areas with optometry servicing, that it isn't picked up by the GP within the AMS, it's picked up by referral to
and I suppose
optometry.
I suppose, Barbara, if there's a long waiting list, people get a bit sceptical about whether or not they should look for it.
Yeah, it's very hard to convince them that there's this process within the hospital system for cataract surgery, and it is a very long waiting list.
Which is the problem you refer to. It's not insurmountable, but you've just got to organise services to get it.
We could operate on all the Indigenous people with cataract by Christmas if we had the will to do so. I mean, it's something that's eminently doable.
Susan asks, I'm a graduate nurse about to start work in southwest Queensland. What aspects of patient assessment should I be looking for to alert me of early stage eye disease? Anna?
Yep, so visual acuity is your main marker, so always check visual acuity. We like you to check near vision as well, to check for presbyopia. As an optometrist, I'm also very passionate about people checking pinhole visual acuity. So if people aren't familiar with what a pinhole is, it's basically an occluder that has a lot of tiny pin-sized holes in it. If someone has refractive error and they look through a pinhole, it's going to improve their vision significantly. So that will quickly tell you whether their vision loss is related mainly to refractive error or a major cause of it. If the pinhole doesn't significantly improve their vision, it's more likely that there's some underlying pathology, which could be cataract, could be something going on at the retina. But importantly, people should have their eyes comprehensively examined by an optometrist every 2 years, and every year if you're diabetic.
So, from Susan's point of view, have a Snellen chart, have a reading chart.
Yep, and a pinhole occluder.
And pinhole as well. So, Joan from Kalgoorlie asks, in regard to improving community access and community knowledge about eye health, can remote health clinicians assist in screening, identifying and providing information to communities, or could there be a particular forum or annual event which could provide an annual health focus in remote communities? What do you think, Barbara?
I think you may be better to answer this, but...
Well, I know in Albany, for example, they have a health fair, which is also happens very often in other communities, where there can be a specific one-off emphasis on health that would include eye health. But I think the practitioners in the primary care clinic, whether they be doctors, nurses or Aboriginal health workers, can do a lot just promoting basic primary care by checking people's vision, and if they have a problem, initiate the referral pathway. You know, you measure blood pressure and you treat it, but you forget to check vision.
I think there is a lot that we actually normally do when we visit remote communities. So both optometrists and the eye team visits will take every opportunity to upskill all the staff that we meet when we're visiting.
But I take your point from earlier, Hugh, the one-off big blitz is really not the way you want to do it. It's got to be, if you do the once a year thing, it's got to be sustainable with a service underneath it.
That's exactly right. And I think that it's making sure that the primary care services and staff actually do that initial step of primary eye care, checking vision and initiating the referral pathway.
Murtaza Kanbai from Queensland asks, does alcohol contribute to eye health problems, and if so, to what extent? Tim?
Yes, it can. I mean, extremely high levels can cause toxicity of the optic nerve, but it's
And
more,
eye injury.
and eye injury is the more direct route where alcohol can cause problems, and there are high levels of assaults and alcohol-related behaviour which can cause significant problems.
There's also been a variable linkage with one of the types of cataract, posterior subcapsular cataract, which is more common in younger people, related to alcohol.
Robin Main from the Optometrists Association of Australia asks, would having more Indigenous optometrists help to increase more Aboriginal and Torres Strait Islander patients to present for eye exams? And if so, what are the universities doing to foster this recruitment? So I'll ask you the first part of the question, Barbara. If you had more Indigenous optometrists, would people be more likely to go and see them?
Oh, very much so. It's the same with Indigenous doctors and nurses. It would help a lot, and it would encourage the community to come in more because they're more comfortable at the level.
Anna, do you know what's happening about in training Indigenous optometrists?
I don't know that there's any sort of optometry specific focus. I know that there are a range of sort of scholarship schemes like the Peggy Hunter Memorial Scholarship for health related practices, but I'm not aware of optometry specific approaches to getting more Indigenous optometrists out there.
There are 2 Indigenous optometrists now, and there are a handful, maybe less than a dozen, who are currently training. But there are also an increasing number of Indigenous doctors, about 120, 130 doctors, and about 150 Indigenous medical students. So there's quite a lot of work there to build up that Indigenous health force. Of course, they'd be terrific, but that's not a rate-limiting step. We've got enough optometrists and ophthalmologists who can provide the eye care we need today. We don't have to wait for a decade or two to train more Indigenous staff, although we want to train staff as quickly as we can.
Final question just for this segment. Simon Day from the Aboriginal and Torres Strait Islander Public Health Journal in New South Wales asks, do the members of the panel consider that the availability of nutritious and fresh foods is an issue in terms of improving eye health, besides putting diabetes and the health effects on diabetes aside?
I was in Beswick a fortnight ago and I was really impressed with the very good range of fresh fruit and vegetables in that store, which is part of the change that's come on through the Northern Territory intervention into the fullest thing. But diet is very important in terms of diabetes. There is some marginal evidence of it being important for macular degeneration, although, as Tim said earlier, macular degeneration is basically not being seen at the moment in Aboriginal people. So
tragically, they don't live long enough.
That's part of it, but it's also partly the genetic basis. 80% of AMD is gene related, and if you don't have the genes to start with, you may not have the same propensity.
Let's talk about Bill's eye health. He's 58 years old, lives in Cloncurry, diagnosed as having type 2 diabetes about 3 years ago. As part of his extended health check for diabetes, he's been asked about his vision. He says it's fine, but he does admit to having some difficulty in seeing small things, although the reading glasses he got when he last saw the optometrist 5 years ago still help him. What should you be doing about this, Anna?
Yep. I guess the important thing to note is his last eye exam was 5 years ago. So just educating the patient about the importance of annual eye exams. And that's where retinal photographs can be really useful. Tim will talk about that a bit later. As a way to show people what the back of their eye looks like and why we're trying to protect it from bleeding. Having said that, this man could still potentially have some severe retinopathy going on while his macula is still intact, and he could still have 6/6 vision. So that's why it's really important to have a comprehensive eye exam to pick it up in the first place.
So it's really only looking in the back of the eye that
Yeah, you
makes
don't
the
know
difference.
it's there until you look a lot of the time.
And it could still be just presbyopia getting worse,
It could be, yep.
which would be good news. So take us through a sort of systematic approach here, and you've got some photographs of retinas for us.
Yeah, I think Dot in the snippet we saw earlier was talking about the different parts of the eye and showed us what the inside at the back of the eye looks like. You've got the central optic nerve where the main nerve comes in and produces that little yellow circle. The red lines are the blood vessels, and the very central part of the vision is slap in the middle of the picture, and it's that part that tends to get affected by diabetic retinopathy within patients that develop the adult onset diabetes, which is what we most commonly see. The aim is to pick the problems up early enough, and I think we've got another picture which shows some of the early changes that you see related to diabetic changes. The damage to the blood vessels produces small areas of bleeding and leaking, and the small white specks show areas where there's leaking within the substance of the retina. Now, it is possible to actually see thickening with the appropriate viewing, and there is some nice new technology which allows us to see and demonstrate the thickening on the scans. It's an OCT, an optical coherence tomographer. The nice thing about that for me with patients is that you can show them a picture which allows them to see that there's clear thickening. The way that the presentation is produced produces a very nice large red spot on the area of involvement, and you can show it to the patient and they go, "That's not good, is it?" And you say, "No, it isn't. We've just got a nice picture there." The little red dot in the top right hand corner, obvious problem, and therefore we need to treat them with laser to stabilise that area.
Now, Tim, I'm delighted for you that you've got a fancy new toy to look at the retina, but people watching this are Aboriginal health workers,
Yep.
GPs working in Aboriginal medical services. What are they looking for crudely to say the alarm bells are ringing?
I'm happy for absolutely everybody to look inside an eye who's comfortable doing so, and anybody who does, if they see anything, we want to see that patient. So little specks of red, little specks of white, and little white fluffy areas related to cotton wool spots, which is the other thing you sometimes see.
So let's see some more of that so that we get a sense of what's going on.
So these are some of the sort of things that you might see. This is actually an eye that doesn't look that bad, but actually has proliferative diabetic retinopathy. That is, there are new vessels at the disc. The little white fluffy bits referred to as CWS are the cotton wool spots. You get abnormal truncation of some vessels, the Irma bit referred to, changes in the big blood vessels, and the other dots and blots that I mentioned earlier.
So that's one that you might miss, scarily.
That is one that you might miss, and it's quite a salutary picture because it doesn't look that bad, but actually once you see something that doesn't look right, you've got to make sure that it's looked at appropriately, and then we can pick up the signs of the proliferative changes, which means that patients need laser. If you manage to get to somebody in time and keep on top of the progression of diabetic retinopathy, you'll end up doing quite a lot of laser for patients. And we've got a nice picture showing now, which is the appropriately treated proliferative diabetic retinopathy patient who has had somewhere in the region of 4,000 to 5,000 burns in each eye.
4,000 to 5,000?
4,000 to 5,000 over a series of treatments. And this young man was able to continue to play cricket and run his business and look after his young kids.
So how many do you do at a sitting?
Normally do around 1,000 burns at a sitting. It depends on the patient's tolerance and how quickly you've picked them up. Some people are easily able to come back for regular shorter treatments, but usually with the remote patients we're looking at, we want to treat them as heavily as possible, as soon as possible when you pick up problems.
That sounds massive, Hugh, but I presume the temptation is to under-treat.
Yes, and I think that's certainly been the feature of a number of audits that have been done both in Aboriginal communities but particularly in mainstream and in developed country settings. And the important thing with diabetic retinopathy is 98% of the blindness can be stopped with appropriate and timely laser treatment. And to get that laser treatment in time, you need that regular exam. Looking for changes in vision and the changes in the retina at the back of the eye.
You've got a series of pictures of somebody you've been dealing with.
Yeah, this is a friend and colleague who's working in an Aboriginal health centre who said recently that she wished she'd realised how serious it was early on, and she's very kindly agreed to let me show some of the series of photos that we've taken. In 2008, here she is having just had very heavy laser in the left eye, so you can see all the little white spots. But she's also got some early changes in the right eye. If we go on to the next year, you can begin to see the local leaking changes in the right eye, but also some...
So where are you seeing them?
In the right eye, which is on the left of your picture as you're looking, the little white specks.
Mm-hmm.
If you look
that's near the macula?
That is right near the macula, so that's threatening her sight, and she will have had some focal macular laser after that. The left eye shows an area of hemorrhage that's more anterior to the retinal surface, so you can see that streak of red across the surface, and that's because she's got proliferative vessels still at the disc which have not gone away, or at least they've regressed but not completely closed down, which is the aim of the treatment. So she then went on to get a progressive scarring process. The right eye now looks far more dramatic because despite the laser she'd had in that eye, she got quite extensive recurrent hemorrhages, and that's what a bleeding inside the eye looks like, and patients will describe having seen these blobs tracking across their vision and getting in their line of sight. And the problem is that you can actually have a relatively clear line of sight with blood all the way around it, and patients will feel like they've got good normal vision, and then suddenly it'll go because you've got this sitting there. The left eye, although the picture doesn't look as bad, had some progressive scarring changes, which happens with retinopathy, and that can then pull the retina off. And so she then went on to have a visit to my vitreoretinal colleague in Adelaide, who cleared out a lot of the scarring and separated the tractional areas, and then put some oil in to help push the retina flat.
This is a vitrectomy?
This is a vitrectomy, yes.
And why oil and not gas?
Oil is more commonly used for some of these patients because the scarring processes are really quite difficult to actually push back, but also because these patients are going to fly back to Central Australia and you can't fly with gas in the eye.
And how's your vision with oil? Because you lose vision with the gas bubble.
The vision is not as good because it does change the refractive index, but it's better to have reduced vision than go blind without treating it.
And as you say, not the bubble in this case. And what about the follow-up? Because it's pretty major eye surgery. It doesn't come much more major than a vitrectomy.
It is, but usually we'll see patients when they make it back into Central Australia, and then when they go to the remote communities, we can bring them in relatively often if necessary and keep in touch with the remote community. And often we will be visiting them in the near future so we can see them back home.
And do people get on quite well at home after this sort of major eye surgery, Barbara?
Yes, they do. I find that in the follow-up with the health workers within those regions after they go home.
So they're pretty grateful for the surgery?
Very grateful, yes. And it's pretty much known in the community too that they can go away, have surgery and come back and still...
Hugh, we've had a question in asking whether the NHMRC guidelines are relevant diabetic retinopathy, I should say, whether they're relevant for Indigenous communities.
Oh, absolutely, and the guidelines have a specific section for Aboriginal and Torres Strait Islander people. The recommendation for eye exams for mainstream Australia is that they need to have an eye exam once every 2 years, because in general in mainstream the goodness of control is such that the rate of progression or incidence of retinopathy is quite low. But in general the control in Aboriginal people is not so good, and so the recommendation is that they need to have their annual examination of visual acuity and the retina. And so what we're saying is entirely consistent with the NHMRC guidelines.
Now, Anna, I know we've been banging on about it, but we really just need to nail refractive error, because I mean this is outrageous. It's a scandal.
Yep. And as an optometrist,
Uncorrected
obviously,
refractive error.
yes, uncorrected refractive error. So I'm sure, being myopic yourself, Norman, you would appreciate if you were to take your glasses off.
Don't ask me to do that.
And try to survive the next
bumping into the wall
24 hours. So we can see the way uncorrected refractive error can affect people's quality of life. We know that it's the major cause of avoidable or treatable vision impairment in Aboriginal people, contributing about half of that. I guess the important thing is it's one of the most cost-effective health interventions you can do in terms of the improved quality of life by providing a pair of glasses for clearer vision again.
Ilviana asks, what complementary and alternative medicines are recommended for eye disease confronting the Indigenous Australian population nationally?
Good clean water. The key for that is...
Nothing more natural than that.
Nothing more natural than water, nothing healthier than water. Good clean water, keep the face clean. And for trachoma, that really is the key, is clean faces, strong eyes, is the key message for trachoma.
And we also have another question here when it scrolls up, is Gerard asks, will we get rid of trachoma ever in this country, and will we certainly do it by 2020?
Well, trachoma disappeared from mainstream Australia 100 years ago with our improved living conditions. In the last 5 or 10 years, trachoma has disappeared because of trachoma programs in countries like Ghana, Oman, Morocco, Vietnam. Now, if those countries can get rid of trachoma, we can. It's easy, it's straightforward to do. In Ethiopia, for example, this year they will treat 28 million people. That's more than the population of Australia. We've got at maximum about 40,000 people in the trachoma areas. So it's clearly within our goals. Prime Minister Rudd 2.5 years ago made a commitment for Australia to eliminate trachoma, and the progress that I've seen just in the last couple of weeks in the Northern Territory is extraordinarily exciting, that real progress is being made. So if we do things right, we can eliminate trachoma easily.
So let's have a look at a remote Aboriginal community, Bulla, in the Northern Territory that Hugh's just been talking about. Health workers from Katherine West Health Board and Bulla community members are using the Trachoma Story Kit to educate people about trachoma and how to prevent it. Let's have a look.
Katherine West Health Board covers a region that's approximately 2% of Australia, so it's a very large area. There are 7 communities in the region, so sometimes you will travel by 4-wheel drive to these communities. Some of them are 600 k's away from town. Sometimes you'll need to fly, and depending on the weather, they may be inaccessible. So to get there sometimes is one of the biggest challenges. The objectives of the Healthy Skin and Eyes program, and I think in particular the Trachoma kind of initiative, is to improve the health and wellbeing of all community members. Australia is the only developed nation to have endemic levels of trachoma in its Indigenous populations, and trachoma is entirely preventable. It's a preventable form of blindness. The trachoma story kits were developed with the Indigenous Eye Health Unit and the Numbin Reference Group, which are unique to Katherine in that they're elders and community members who help to guide the way in which we make health promotion resources.
My name is Jack Little. I'm living in the Buller community since 1975, and I was the first Aboriginal health worker in Katherine West region. Well, my role is to educate my people while they're still young and make them be aware of all the health matter.
So we're going to show you some pictures, and Jack's going to talk to you about what happens if you get too much of this trachoma bug. So if you can share, and then we're going to collect them up. So there should be
See
enough.
this top one here? The image they're called, that's the eyelid. When he turn in, he make it eye go manang, blind, you can't see, it's getting worse. Manang, okay?
Once someone has repeated episodes of trachoma, there's a chance that they'll develop trichiasis, which is a interning of lashes that rub against their eye, and if untreated that can cause blindness. So one of the aims is to identify those people with trichiasis and offer them surgery within an appropriate time frame. As a clinician, I think the trachoma kits are valuable because they help you to, I guess, improve your skills in recognising trachoma and also trichiasis.
Well, with the kids, the trachoma kit is really good because it actually shows you how they get trachoma and what happens and how you can prevent it and all that stuff. It's all about the education, the screening, and then the follow-up and the importance of hygiene. Because if you don't follow up with the hygiene, you may as well be flogging a dead horse.
You start getting runny nose because they didn't wash their face. And that's why this one got it now. You know, because we cannot see the germ that we're looking for with the natural eye. And we can look at a microscope, all these little bad things in our mirror, all right? If they don't understand, well, I speak a language. I say, yela mawanga, mila janga. That means if you can't wash your eye got to go no good. Bug it up. And we are lucky. We got a big river beside us, and we got to heat the water in the bathroom or wherever. So the kid can go and wash their eye, and they wouldn't get it. Out in the desert, too much dust, and there's no water at all. That's the reason too much. Out in the desert, they're getting too much bad. They come.
The trachoma team actually organised for a mirror to be put out in the front room, and we noticed that the kids are using it a lot, and then from there we'll just say to them, you know, what do you think your faces look like today? Is it clean or does it need cleaning? And then we can assist to clean it, so it's all a part of the hygiene business. But that mirror's been a great help.
I think what kids tend to walk away with at the end of a program is that clean faces mean strong eyes, and I know that that's branded throughout the trachoma story kits, and it's a message that they seem to take home and enjoy. And you know, the kids will run up to you in the community and say, you know, clean face, strong eyes, see miss?
Our thanks to the Buller community and Katherine West Health Board for allowing us to film that great example of prevention. I'll come to trachoma in a second, because I had just a few questions in about refractive error while that film was on. First of all, we've asked that question asking about the spectacle schemes that might be available for people. There's a bit of confusion about what's available and what's not and how.
Yeah, I guess there's confusion because there's so many different schemes in all of the different states. So some schemes cover everyone who's on a healthcare type card, such as the Queensland scheme. The Northern Territory scheme covers you if you're on a pension card. So that means that people who might still be low income earners and can't necessarily afford spectacles through sort of optometry shops can potentially miss out on correcting their vision. So because of that, there are a few small sort of low-cost spectacle schemes with more flexible payment options available, and that has significantly increased people's uptake on glasses simply because they can now have an affordable option to correct their vision.
Once they've got the glasses, Barbara, do they wear them?
Yes, some they don't, but the ones they're picking now with the metal frames is...
so because it's better style of frame,
a better style of frame. They've still got the old plastic ones, which aren't popular.
And a question from Dom asks from New South Wales, are there any data or is there any experience on the safety of routine pupil dilation for looking at the fundus without doing an assessment for glaucoma in Indigenous populations? Tim?
Yeah, in fact in the studies that we did, one of the steps we put in as part of the assessment was a shadow test where you basically shine a light from the side of the eye, and if there's a significant shadow it means that the front part of the eye is shallow, you've got a shallow anterior chamber, and those are the patients that are at risk of dilation. Now in fact the incidence of provoking angle closure glaucoma is something like 1 in 60,000.
So it's pretty low
not common,
anyway. Yeah.
and I usually say, look, I'd far rather treat that one patient if it means that all the others have been looked at properly.
And Norman, we mentioned the NHMRC guidelines, and they clearly recommend pupil dilation for people with, to examine retinopathy. The benefit far outweighs any theoretical risk.
Yeah, it's like opening the door rather than looking through the keyhole.
And Robin from Queensland asks, Anna, could you break down the refractive error types for Indigenous people, presbyopia, myopia, hyperopia, astigmatism?
Mm-hmm. Yeah, I don't have exact stats on what contributes exactly, but definitely hyperopia is more common than myopia amongst adults. There have been changes in more recent years of a relative myopic shift a little bit, and that could relate to slight change in lifestyles. People now looking up close a lot more than they previously had done.
Getting away from the far horizon.
Yeah, perhaps, yeah. But presbyopia, pretty much everyone, once they get over the age of 40, yeah, give or take a few, everyone on the planet will get presbyopia, so that affects Aboriginal people equally.
Thank you very much. And astigmatism?
Relatively rare.
Relatively.
Most of the astigmatism goes with high refractive error. We did a detailed study some years ago looking at the distribution of refraction in Aboriginal and non-Aboriginal adults. And Aboriginal people basically don't have the degree of myopia, low, medium and high myopia that's so common in Caucasians.
And that's exactly what we found in Central Australia as well.
Hugh, just briefly, what is trachoma?
Trachoma is a chronic eye infection caused by Chlamydia trachomatis, a bacteria. And children get infected in the first years of life, and if you look underneath the eyelid you'll find this swollen, inflamed conjunctiva with little trachoma follicles. And that inflammation goes on and causes scarring, and you'll find underneath the eyelid in older children and young adults scarring, and with time that scarring will contract.
I think we've got some photographs of that.
Yeah, and turn around and turn the lashes in. So the top left-hand photograph there shows the swollen conjunctiva with the follicles. The top right-hand photograph's got the scarring, and then the bottom photograph you can see these lashes turning around, called trichiasis, rubbing the front of the eye, rubbing the cornea to go and cause blindness.
So Hugh, talk to me about the distribution of trachoma across Australia.
Well, trachoma still occurs in about 2/3 of the remote communities, and this map shows that particularly in Central Australia, but also in Western Australia and South Australia, trachoma is still a problem. WHO has set a threshold of more than 5% of the children having active trachoma as a threshold of trachoma as a public health problem. And we also know there are at least isolated pockets in Queensland and in New South Wales as well.
And the determinants?
Trachoma really occurs around poor hygiene, and again I think we've got a graphic that shows this sort of cycle of poverty, crowding, decreased water supply, but the key to it all is facial cleanliness, or the lack of the children having a clean face, because those infected secretions can easily pass from one child to another and continually restoke the infection and the inflammation.
Diagnosis?
Diagnosis is relatively straightforward. You need to, as we saw Jack Little in that video clip showing all those WHO photographs, but you avert the eyelid and look at the undersurface of the eyelid. If you're doing a standard grading, you would use loops, 2.5 time loops and a torch. But Fred Hollows used to teach me that a blind man on a galloping horse on a dark night without a light could diagnose trachoma. All you have to do is look at it.
Tell me about the WHO SAFE project.
Yes, the SAFE strategy is the strategy WHO has developed to combat trachoma, and it's got 4 elements, and the acronym SAFE actually puts them in the wrong order from a public health perspective, but it's better than EFAS. But S stands for surgery to correct the intern lashes, the trichiasis. A is the azithromycin or antibiotic treatment to eliminate the infection.
And that's once a year?
That's once a year or once every 6 months if you're in a hyperendemic community. So if the rate's very high, it's probably worth treating everybody once every 6 months. So annual or twice annual antibiotic. Then the F is for facial cleanliness, as we saw in that video clip, clean faces, strong eyes. And then the E is environmental improvement. And in the Aboriginal communities, that really is making sure that the washing facilities are safe for the kids to use. So they can get to the basins, the taps work, the drains work, having mirrors and that sort of stuff, so the kids can keep their face clean. We need to change the social norm so it's not acceptable for kids to run around with dirty faces.
Let's talk about Mavis, who's 70 years old. She's been complaining of sore eyes. She's come in from a remote community to Mildura to live with her family, and she comes into the Aboriginal Medical Service every few weeks complaining of the sore eyes. She's given artificial tears, soothing eye medicine, but each time she returns with the same problem. She was seen by the ophthalmologist about 5 years ago, who didn't notice any particular problems, and she was also seen by the optometrist, who gave her reading glasses, but this didn't help her symptoms either.
Well, I think this illustrates the problem of trichiasis. Even though Mavis may be seen in a rural area, if she grew up in a remote community, she's very likely to have had trachoma as a child. And the 3 things we've got to remember about trichiasis are the 3 T's. The first is you've got to think about it. If you don't think about it, you won't look for it. The second is you need to use your thumb to lift up the eyelid so you can lift the lashes off the globe if they're touching on the globe. And the third thing, you need a torch because it's dark in there, so you need to be able to see these black lashes. And it's really, really important. You should never let any Aboriginal person walk out of your clinic who's coming complaining of sore eyes without specifically excluding the presence of trichiasis. Because if they have trichiasis, they can have the surgery done to rotate the eyelashes and the lower eye margin so the lashes point out and save their vision. And you can see in this photograph at the top, it's got trichiasis with the lashes pointing down and rubbing on the eye, and the bottom photograph is after surgery with the lashes pointed out. And you will stop people going blind by doing that.
And can you do that surgery locally? Is it?
It can be done in the community if you have a treatment room or sometimes in a dental clinic, but often it's easier to bring the patients into Central Hospital as Tim would do in Alice Springs.
Must be very satisfying when you've treated it properly, Barbara.
Exactly, yes, it'll be more comfort for the...
And to what extent are communities aware of trachoma?
Well, most of the communities would be if they're in a sort of an area where it is pretty prominent within there, and it's been generations of it, and it has been before, but places like Queensland where it's not very prominent, it's probably...
But still occurs.
But still occurs,
Yeah.
but it, like I say, it's not identified by the GPs.
The point that we found there is that while the community knows there's trachoma there, we found that 1/4 of the clinic staff and 1/3 of the teachers don't realise they're in an area where trachoma occurs. So if they don't realise they're in a trachoma area, they're not going to start doing anything about it or even looking for it. So it's really important for the clinic staff to know whether they're in an area where there is trachoma, so they need to be vigilant and aware of it.
Injuries, ocular injuries?
Ocular injuries are a very alarming subject, but actually fortunately not that common. The recent study by the Australian Institute of Health and Welfare was looking at this on a national level and found that around 6% of ED admissions, emergency department admissions, were related to eye problems. Of GP consultations, only about 1 in 500 was related to an eye injury. Of those presenting to ED, only 3% actually require hospitalisation. and most of those, or 2/3 of them, occur in men. So men are more likely to be involved in trauma that will result in significant ocular injury. About a third, about a half, have bony fractures around the eye and superficial injury, and most of them have been caused by falls, assaults and motor vehicle accidents. What's interesting is that hospitalised eye injuries are 3 times more common in the Aboriginal population.
So when they occur, they're more severe?
They tend to occur, they're much more severe.
So what are the golden rules for looking after somebody in this situation?
Golden rules are, if you think there's been a chemical splashed in the eye, then start washing out immediately, irrigate the eye, and then start asking more questions. In other words, the sooner you get on with the irrigation, the better.
Even though you think there might be a penetrating injury as well?
If you think there might be a penetrating injury, you do the minimum necessary to decide whether or not you need to be worried about it. And as soon as you're worried about it, you need to send that patient for specialist care and attention, where they may require surgery.
So quick assessment.
Quick assessment.
And triage.
Yes.
And is the CARPA manual much help here?
The CARPA manual is excellent, actually, and both the CARPA and the CRANA manuals, the outlines on how to assess eyes are brilliant, and they're really well written for allowing people who have very little experience looking after eye problems to be able to do a step-by-step guide as to what they need to do, both for checking visions but also things to look for, and suggestions on making sure you put some anaesthetic in to make it comfortable for the patient whilst you assess them properly, and using some fluorescing eye drops to see if there's any evidence of surface damage. And if you follow the steps that are in the CARPA and CRANA manuals, it'll make it much easier if you're not sure what you're doing. Really good resource and widely available in the remote communities.
Do you want to comment, Hugh?
Oh, I think the 2 manuals are excellent.
Hugh, you've looked quite a lot at the provision of services, the coordination, and you see it as a system problem as much as anything.
Yes, I think there really is a health system issue here about the need for really good coordination, and we've looked at this in a number of different ways. One thing is to look at how well the visiting eye services are coordinated, the visiting optometrist, ophthalmologist coordinated with the visits themselves, with the clinic or with the local hospital. And we assessed a number of different projects, and those that were well coordinated were far more efficient. They much more, cost less, saw a lot more patients, much higher throughput, because there was not the reduplication. People were doing things that they should do.
Before Hugh goes on with that description, describe good coordination to me, Tim.
Good coordination is ensuring that the patient flow, the patient journey, does not hit roadblocks at every single opportunity. In other words, you pick up patients promptly, you make sure that those that need further specialist attention are transferred appropriately with the right support in a timely fashion so they get the care they need as soon as possible.
So Hugh, everybody knows the clinical pathway?
Well, that's in the good services, that's what happens. In the other services, you'll find that people are not sure where to go or how to refer, or not able to reach the service. Or you might have, one eye practitioner come today and another one come next week without any communication between them. So it really is important to have that patient pathway properly coordinated. There's so many steps along the way that patients can leak out of that pipe, if you like. Whether you're going from the GP to waiting to see the optometrist, being referred by the optometrist to the ophthalmologist on a waiting list for surgery. So that it's really important to have that well coordinated and organised.
We'll just go back to those first graphs that you showed there, because they're really quite dramatic in terms of the impact of coordination. I didn't give you enough chance to explain.
Well, the other thing, that one of the graphs that we did go over that we found particularly interesting, which is the next one after this, is showing the impact of having an optometry service in an Aboriginal medical service.
Which is what you were talking about earlier.
Earlier, that's right. So there's no correlation between how much optometry services, how many optometry services are available in a town or a community in terms of Aboriginal health or visual health. But the longer an optometrist stays working in an Aboriginal health service, the better the vision and eye health of the Aboriginal people is. So that really gives that importance of integrating these visiting eye services into Aboriginal medical services.
Barbara, what's your take on the ideal service or model of care, or different models of care that you've seen that work?
Well, what I feel that does work well is starting with the regional coordinator, going into the communities, preparing the communities for, or making them aware of that for eye checks, bringing through optometry, the referral pathways from getting those patients from the community up to a consulting ophthalmologist is the pathways, which is very difficult, even in rural and remote areas, is the transport. and in the urban areas with the AMSs, if optometry services there is getting into the hospital system, which is a very long wait. But it's coordination with the coordinator. The regional eye health coordinator plays a huge role in going even outside the AMSs to rural and remote areas where there's not many AMSs, but there are health services in that area, and working with other different health services as well to target communities outside the AMSs where there isn't an AMS as well, and also working closely in the AMS to move pathways into the hospital system.
But everybody knows what's happening.
Yes.
And Anna, well, tell us about the Visiting Optometrist Service.
Yep, so Visiting Optometrist scheme is a Commonwealth funding scheme, basically to fund outreach optometry. So as the maps previously showed, the distribution of the eye care workforce across Australia is currently inequitable in terms of the glut of service providers being in the major metropolitan areas, and the more remote and the more very remote you go, the greyer or whiter it got on those maps. So VOS exists to try to encourage and facilitate and enable optometry services to be provided in remote and very remote locations.
But as Hugh said, if they're not coordinated, and the right hand doesn't know what the left hand's doing, you're not necessarily going to make it a lot better.
Absolutely, and any optometrist who participates in a VOS program should absolutely work with the regional eye health coordinator within the Aboriginal Medical Service jurisdiction, and particularly with the ophthalmologist in that region as well, to make sure they're working in the most appropriate and effective ways in terms of a team-based approach.
And the Medical Specialist Outreach Scheme?
The MSOAP for short is another Commonwealth-funded program which aims to support outreach work by medical specialists to as many remote communities as possible. It covers quite a lot of specialty areas, but does also support some of the eye work too. It's a little bit different in different states as to how much it's actually integrated, and at various stages it's sometimes been more supportive or less in my experience.
Hugh, what resources are available for people interested in this area?
When you asked that question, I was thinking, how much more money do we need to properly fund MSOAP and VOS, and I'll take a rain check on that one. But as far
But I assume that money is not necessarily the answer here.
It actually is a lot of the answer, in that we need to make sure that the service are properly resourced to provide the needs on a sort of a population basis. And so we need to have 2 or 3 times as many visits through MSOAP and VOS. We need to have maybe 4 or 5 times as many people in sort of the role that Barbara plays as a regional coordinator and coordinating those patient journeys. And they need to be people specifically identified. So money is a need in that larger scale. But I think in terms of things that are more immediately doable, like trachoma control, there's some great material that's been developed, as we saw in that video clip, and developed really with the community involvement and consultation, promoting this clean faces, strong eyes message, and the goanna has become the mascot on this, and it was actually launched publicly in the Darwin at the footy match 10 days ago. And I think that there's a lot of resource material for the primary school kids, at the clinic level, at the community level, to try to help change that social norm about facial cleanliness.
And clinical guidelines as well.
And clinical guidelines and detailed instructions on how a Aboriginal health service or a community health service or a region can put together and manage a trachoma control program. And there's some really exciting results coming out of the Northern Territory, particularly in WA, over the last 6 or 12 months. Some real progress is being made.
And you want to suggest some resources?
Yeah, there's other resources around general eye health education that IC has developed, again, through consultation. So these are the IC for Culture Eye Health educational resource kits. So they're largely image-based. So there's a couple of flip charts, and they talk through understanding about common eye conditions, particularly covering diabetic retinopathy, cataract and trachoma. And they're basically designed to assist health workers to educate their patients, and particularly understanding about what treatment can be done to prevent those conditions.
What are your take-home messages for the audience?
Well, I think for the people working at a primary care clinic, there are 2 things or 3 things that I'd really emphasise. One is the need to check to check vision, near vision and distance vision at every health check. Another is to make sure that all the people with diabetes get their eyes looked at every year. That's really important. And the third, for any of those in the outback communities, keep the kids' faces clean.
Barbara?
Yes. Is the annual eye checks to have their eyes checked, even when they go to see their GP. And I feel GPs should be a little bit more trained in the area for eye health. But when they go to the GP to bring forward, if there's no optometry, to make sure that they get their eyes checked or referred to an optometrist.
And don't take, Doc, I've got no problems for an answer.
No, exactly.
Anna?
The main point I would want to get across is to community members that losing your vision is not a normal part of getting older. Most of it is either preventable or treatable. So take care of your eyes, get them checked every couple of years or every year if you're diabetic, and you can live a life with great vision.
Tim?
Summary. Let's close the gap, not our eyes.
Good way to finish, and I hope you've got a lot out of this programme on eye health issues in Aboriginal and Torres Strait Islander communities and the importance of prevention, screening and treatment. We're grateful to the funding bodies for making this programme possible. They include the Australian Department of Health and Ageing, the IOOF Foundation, the Vincent Fairfax Family Foundation, Aragan, Australia. And we gratefully acknowledge the services and staff that helped produce the case studies and provided the photos. You can see them on the screen. Thanks to our panel members for contributing, but thanks also to you for taking the time to attend and contribute. If you're interested in obtaining more information about the issues raised in the programme, there are a number of resources available on the Rural Health Education Foundation's website, rhef.com.au. And there's some other links for you, but they'll be on the website as well. Don't forget to complete and fill in your evaluation forms to register for CBD points. I'm Norman Swan, and I'll see you next time.